My name is Claire Bowsler. I'm 35 years old and I have a number of different conditions, but really my health journey begins when I was 9 years old and I was diagnosed with ophthalmic arteriovenous malformation with Steele syndrome. And that's a group of blood vessels in my brain that haven't formed properly, and it means I'm more susceptible to having brain hemorrhages. So I've had 4 brain hemorrhages over the last 25 years. I've learnt in the last few years that a brain hemorrhage is very similar to a stroke. In addition to that, when I was 18 years old, I was diagnosed with insulin-dependent diabetes. And in very recent times, in the last 6 months, I've been diagnosed with heart failure as well. So I have several different conditions, and the neurological condition itself has lots of different symptoms and impacts on different things. So I have a wealth of different experience of healthcare and healthcare professionals within the NHS. I see something like, at one point I think I worked out I was seeing something like 14 different healthcare professionals on a regular basis. And of course many of these healthcare professionals operate in different trusts or different hospitals or completely different sectors, and they don't talk to each other. And so the only person that knows what everybody is saying to me and all of the advice that's given is me. I often say to professionals that I have to project manage my healthcare because there's so many different strands to keep control of and to manage. One of the treatments that I have to help manage my stroke symptoms and the weakness I have down my left-hand side is I have some Botox injections, not to make me look younger or more beautiful, but to relax the muscles in my arm and my leg. Claire Madson's been working with me since over the course of the last 8 years or so to help deliver those injections and help manage my spasticity.
Our relationship's developed over the years, and I think one of the things that it's really benefited from is the open conversations that we've been able to have, and we've later come to talk about that as a very specific technique called shared decision making. But at the end of the day, shared decision making really is just a technique of having much more open and meaningful conversations. So shared decision making is defined in many ways in lots of the literature, but really it just means that instead of having a traditionally paternalistic relationship where the clinician is the expert and tells the patient what they should be doing and the patient's the passive recipient of that advice or treatment, shared decision making recognises that there are 2 experts in the conversation. There's the clinician who may be an expert in that particular area of expertise or ability to give treatment or actually do things with somebody, but the patient brings their own expertise, their experience of living with that condition, their own culture, their own belief system, and also where they are in their lives at that moment in time. Somebody in the early stages of diagnosis is in a very different place from somebody who's been living with the condition for many years. So our job together is to come to an agreement as to what's important for that person at that moment in time.
Well, they'll know the medical side of what they're suggesting should be the next step for me. They don't understand the impact that necessarily has on my day-to-day life. I work full-time and lead a very normal, active life, and so sometimes the decisions that they're making or suggestions they're making about changes in drugs or different possible treatments and things can have an impact on my day-to-day life that they may not be as aware of, but through shared decision making we can talk about my priorities and what impact some things will have and come to a shared decision about what's going to be the best next step.
My job is to really understand where that person's coming from and what's important to them. I may have one agenda and Claire may have a completely different agenda, and whilst I might have to explain to her why something I want is important, she may say, well, that's all very well and good, but at the moment I'm so struggling with my diabetes I can't even think about anything else. So even though that's not my area of specialty, I really have to talk to her about that and understand how we can fit round that problem at that moment in time.
I'm Val. I'm 77 years old. I was born with spina bifida, so I've been disabled all my life. I am independent. I'm quite an active person. I'm a volunteer in Southmead Hospital. I'm also a wheelchair dancer.
I met Val several years ago. She'd had a fall, so not so much a fall, but she'd misjudged a transfer from one of her wheelchairs to another and ended up lowering herself down onto the floor. In order to get to her device that she had called an ELK that can help you get back up off the floor, she dragged herself from one room in her bungalow to another, causing what we know as a deep tissue injury to her bottom.
It wasn't until about a week later I realised what damage I'd done to my backside. If it hurt, you wouldn't do it, would you? But when you've got no feeling, you know, you don't realise what you've done. Didn't seem very much at the time, but it ended up being grade 4 pressure sore down to the bone.
As clinicians, we know that in order to heal anything like a pressure injury or any wound, actually, you don't want to be putting pressure on it.
They suggested I ought to at least go to bed in the afternoons, which I wasn't very receptive to because I was busy. I had other things to do. My lifestyle was quite important to me.
And she really just couldn't entertain that. We did have lots of discussions about how these injuries heal and how important it is to offload them. And we had those discussions on numerous occasions, but she really couldn't entertain going back onto the bed for any length of time.
I felt I just couldn't do it. I felt it was impractical to say do it for a start. And of course when tissue viability got involved and they said the same thing and the plastic surgeon said the same thing, it was, you know, it's my life and I have to make the most of it as I can, and I felt if I was spending time in bed all the time, that was being taken away from me.
So we had to find compromises. So there are other things that we look at. So we look at the seating, we look at the cushion that she was sitting on. We upgraded her to what we call a RoHo cushion, which is floating in air basically. We pressure mapped her. I felt that her transfers could be improved. The fact that her dressings were coming off on every transfer meant that she must be scuffing them a bit. She was a little bit reluctant for me to refer her to an occupational therapist. Eventually, through discussion, it transpired that she really felt that being referred to other services meant that somehow she wasn't managing at home, which would be the downward slide for her losing her independence. And her greatest fear was to lose her independence. And I did say on many occasions that our services were all about keeping people at home and maintaining their independence. I think building trust and a partnership with your patients is what's crucial, so that she did allow us to refer to occupational therapy eventually, and with a really good outcome. I
was part of the process. I wasn't told to do this or do that, you know. And as a very independent person, that is very important.
Some of the discussions that we had together were about the length of time that this might take to heal if we weren't able to offload and have those periods of bed rest. So Val was much happier to make compromises, and she understood that the healing time would take longer. And it did actually take 4 years.
But we got there in the end.
People live with long-term conditions and their interaction with healthcare may be just hours in a year, and the other thousands of hours they live, they're self-managing. And if they can take control and understand their conditions and know when to do something and when to act and can prevent deterioration, then they will feel much more confident. But also as a system, we're struggling to manage people with long-term conditions now. And if people were feeling more empowered to self-manage and to do proactive things to prevent themselves deteriorating, then that would benefit the whole health system.
I've acquired lots of skills around things like people's activation levels and how engaged people are with a situation, and I use those through my work now as well in line management meetings and things, one-to-ones, and some of the skills around priority setting and getting people to say what's most important to them is really important when you're trying to get buy-in to different projects and things. And definitely the skills that I've learned through shared decision making and through working on projects I've worked with recently with helping with developing the training for shared decision making at Bristol Community Health I've been able to use those skills within my work environment, and they're very transferable.
I think shared decision making is a really essential way forward. It's a really great idea. If everyone had this skill set, they would feel much more confident and empowered to self-manage themselves. The system would have less pressure upon it because people wouldn't be accessing the system at short notice, and in a crisis everybody would feel able to access the healthcare that they needed at the time that they needed it, rather than a very reactive system, which is what we have at the moment.
I think when you're dealing with a long-term condition in particular, but with any sort of health problem, you can feel quite out of control. And you can feel like you don't know what to do, and your confidence can be taken away in terms of your health, and you can be really worried. But through shared decision making, you can be given the information you need to make a decision and to see what your options are. It highlights that you have a choice in the situation, and that you haven't got to go down just one route. There are options, and that allows you to feel more in control of the situation. It's so helpful in all parts of my health, no matter whether it's my mental health and when I'm dealing with counsellors, or whether it's the GP and trying to get them to prioritise what I need them to prioritise, or whether it's the receptionist when I'm ringing up to change an appointment, or whoever I'm dealing with within the NHS. I just think that those skills are really helpful, but then the fact that it also translates to my work as a statistician, and that is just so, they're just great skills to have in every aspect of what you do.